Good morning, everyone. Welcome to the Harvard Medical School Osher Center for Integrative Medicine Grand Rounds. My name is Gloria Ye. I'm the the director of clinical research. Thank you so much for joining us this morning. If you are requesting CME for this session, please see our event post on oshercenter.org for email request instructions. We'll be using the QA function in Zoom so that you'll be able to type in questions during the talk, and I will help to moderate and pose these questions to Dr. Ring at the end of her talk. So I'm very delighted to introduce our speaker this morning, particularly because she joins us from one of our sister sites, the Osher Center for Integrative Medicine at Northwestern University. Dr. Melinda Ring is the executive director of the Osher Center for Integrative Medicine at Northwestern University. While earning her medical degree and completing her internal medicine residency at the University of Chicago, Dr. Ring's passion for complementary and integrative medicine evolved along with her holistic philosophy of needing to treat the whole person to achieve true health and healing. Following residency, she completed a fellowship in integrative medicine at the University of Arizona with Dr. Andrew Weil. In her role at Northwestern, she maintains an active integrative medicine consult practice, oversees the medical trainee integrative medicine and culinary medicine education, and conducts research in this area. Her expertise is reflected in her contribution to academic textbooks, lectures, and research articles, and her first consumer book on integrative women's health called The Natural Menopause Solution. She's also active on several national policy committees, including the board of the Integrative Medicine Credentialing Exam. Her interests include women's health, food as medicine, dietary supplements, mindfulness, and the healing power of nature. She's passionate about raising awareness of the power of integrative medicine to heal ourselves and our healthcare system. Welcome, Dr. Ring.
Thank you. Thanks so much for having me, Gloria. It's nice to be with my cousins at the Harvard Osher Center. I'll go ahead and share my screen so we can jump in. All good? You can see it?
All good.
I'm going to assume that's a yes unless I hear otherwise.
Perfect.
All right. Thanks, cuz. Okay, so today we're going to talk about culinary medicine and the science of the teaching kitchen. I think amidst everything that's happening in the world today that emphasizes divide and differences, one commonality remains, and that's that we all need nourishment. I'm going to share with you today what I think is one of the most exciting innovations in medical education, that of culinary medicine. My hope is that after seeing the data, you have a greater appreciation for yourself, for patients, for communities, of how critical nutrition is to health and why we need to find innovative strategies to bring this content to all health professional schools. I don't have any conflicts of interest. And so today we're going to jump in by just some definitions, differentiating between teaching kitchens and culinary medicine. Again, talk about the link between diet quality and health, and what is the role of the health professional. And then what are gaps in nutrition education in health professional training, and potential solutions to meet those gaps. And I'll share with you some data from our own Cooking Up Health culinary medicine program. So the term culinary medicine's been co-opted by chefs and foodies and influencers, but today what we're thinking about when we think about culinary medicine is that it's a medical intervention with the intention and the goal of preventing and treating disease. Dr. John LaPuma defined this rapidly growing field as a new evidence-based field in medicine that blends the art of food and cooking with the science of medicine. And so in this way, we're moving beyond just basic nutrition knowledge, and we're adding practical culinary approaches to assist patients in achieving and maintaining optimal health. So health professionals who embrace culinary medicine are really shifting from reactive therapeutics to a more functional root medicine cause approach, where nutrition and healthy food preparation take front stage. The other thing that's different is that the model is a team-based approach, but we're adding a new partner into the traditional medical team, and that's of the chef instructor. And the chef instructor can either be a professional chef who has good teaching skills, or it can be a health professional who just loves to cook. And so this is really a new paradigm in terms of team-based medical care. In contrast, a teaching kitchen can be described as a virtual learning laboratory for life skills. And while teaching kitchens are increasingly being found in hospitals and clinical settings, they also can be part of a school or a community organization. They can vary from just being a pop-up demo with just cutting boards and knives to a fully equipped built-in kitchen. So what happens in a teaching kitchen? This is from Family Cook Productions, which is an organization that helps implement teaching kitchens. And this is what they list as the fundamental components. So the first is nutrition education, informing participants and learners about the nutrients in food, how they function in terms of supporting health, how to compose balanced meals, meal planning strategies that take into account a participant's resources and what is their access to healthful food. Are they living in a food desert or a food swamp? And how does that impact their ability to actually do things that instead of just telling them to go do something, but then they don't have the resources. Hands-on culinary instruction and practice is really the keystone here, and what differentiates this from just watching a nutrition YouTube video or going to a medical talk. And then goal setting and group support. And we know that groups have power in terms of participants learning from each other and supporting each other, and that can be an important part of the teaching kitchen as well. So just to show you some examples of what a teaching kitchen can look like, it's diverse populations. It's our youth. These are kids in a school setting from Common Threads, which is our nonprofit partner I'll share with you later. Teens. This is a great program called Teen Battle Chef. And we're seeing this also in colleges where they may be actual courses teaching college students about food preparation and healthy food. Like UCLA, Northwestern have these types of classes. And then, of course, patients are another one. These pictures are from, on the left are from Kish, which is a Northwestern affiliated hospital where they have a full built-in kitchen. And then on the right, we're seeing pop-up workplace kitchens. It can just be this is actually a backdrop that looks like there's an oven, but no, these people are just sitting at a constructed table with a chef in the front, at a table with a cutting board. On the bottom, we see the other extreme, which is teaching kitchens that have been implemented at Google, where they have, top line appliances and, of course, technology to help where you can see the instructor on a screen overhead. And then where we're going to focus today is really in that of the medical profession. And I'll share later some examples of continuing education that is teaching, practicing health professionals how to prepare food. But my main interest personally is that in health professional trainees, because I think it's so important that our future frontline physicians and other health professionals have the knowledge and confidence to be able to counsel patients. The culinary medicine and teaching kitchen movement has really taken off over the past 5 to 10 years. And this is in large part driven by the now undisputable fact that nutrition is related to chronic disease such as heart disease, cancer, and diabetes. And these chronic diseases are the leading causes of death and disability in the United States, as well as major drivers of the cost of our annual health care. So in our country, 6 in 10 adults have chronic disease. 4 in 10 adults have at least 2 chronic diseases. And these are all impacted by what they're putting on their plate. More recently, in the COVID pandemic, we've seen that chronic diseases like diabetes, hypertension, heart and lung disease are comorbidities for COVID-19. And also, we're seeing data that shows that obesity and chronic disease not only increases the risk of infection, but is associated with significantly more severe outcomes in the intensive care unit, increased risk of deaths. So what's the link of nutrition to death rates in the United States? Well, this was a publication in 2018 by the U.S. Burden of Disease Collaborators. And they published an updated list of risk factors that were influencing disease burden in the US population from 1990 to 2016. And you can see in the top that dietary risks were identified as the #1 risk factor for premature death. This is over things like high cholesterol, high blood pressure, unsafe sex, sexual abuse, dietary risk, #1, even higher than tobacco use. And they were listed as #3 for disability. Around the globe, we're seeing similar data. This was the 2019 Global Burden of Disease study that looked at 195 countries. And again, dietary factors were the #1 leading cause of death, exacting an even greater health burden than smoking. They stated that improvement of diet could potentially prevent 1 in 5 deaths globally. So what is it about nutrition specifically that makes a difference in mortality and morbidity? Well, the consensus actually is growing, and there's a lot of common agreement in terms of what that is. So despite the debates about keto versus paleo versus fasting and other, there are some really common themes that run throughout and which we can all use as guidelines for what we should be eating. The Nutrition and Chronic Disease Expert Group completed systematic reviews and meta-analyses to associate specific dietary factors with mortality, in this case due to heart disease, stroke, and type 2 diabetes in US adults. And based on a comparative risk assessment model, they estimated that 45% of cardiometabolic deaths were attributable to suboptimal intake of 10 foods and 7 nutrients. Those that were found to be protective and that we should be including in our diet are things like fruits, vegetables, beans and legumes, nuts and seeds, whole grains, fish, yogurt, fiber, seafood omega-3s, polyunsaturated fats, and potassium. Those found to be harmful were unprocessed red meat, processed meat, sugar-sweetened beverages, glycemic load, your sugar load, trans fats, and sodium. And June 30th, recently, we just had the report released from the 2020 Dietary Guidelines Advisory Committee. This is the report that's going to be used in preparing the 2020 to 2025 dietary guidelines for Americans, the guidelines that are redone every 5 years and are going to be due out later this year. And we can see here that the report highlights very similar dietary patterns as the last slide, but emphasizes, you can see in the blue box, that not only is it cardiometabolic disease, but also associations with all-cause mortality, with bone health, with various cancers, and even with neurocognition. So how healthy is the American diet? So every 5 years, I said, we get these dietary guidelines. And this has been happening for decades. How well are Americans following them? And the Healthy Eating Index is the number that's used to measure our population diet quality and how it aligns with those key recommendations. An overall HEI score of 100 suggests that the set of foods that are being eaten are completely in alignment with recommendations. And you see here that the HEI 2015 score is pretty poor at 59. On the right, you can see that older adults, those age 65 and up, were doing the best with a score of 66. And I think in a scary thing, since unhealthy children become unhealthy adults, that children from age 6 through the teens into age 17 had the lowest scores at a match of 53. Dialing in a little bit in that report in terms of what is going on and where the dissonance is, you can see the blue line shows 0, meaning that it is aligned. And we see that total vegetable, total fruit, and dairy intake were significantly lower than recommended amounts, while grains and protein foods, which includes, and this is shown in other graphs, includes refined grains and processed meats, exceed the recommendations. Looking over time back to 1999, we're really not doing much better. Our score from the 2015 HEI was 59. Looking back, it's ranged from 55 up to 58. So we're a few points higher, but overall our scores are very, very poor. That's in adults. What about in children? Well, we can see in the orange that since 1999, there has been some decrease in and some modest improvements in the overall diet quality of US youth, declines in the number that were characterized as poor quality, but still more than half of youth fell in that category. So given the preponderance of evidence that links poor diet to premature death and chronic disease, there have been calls across the healthcare field for nutrition to play a larger role in the provision of healthcare. This was a recent 2020 call to action, and it listed several key actions ranging from food as medicine interventions. These are things like medically tailored groceries, produce prescription programs like VeggieRx, where doctors can prescribe vegetables for their patients, research into different approaches to really help designate which ones are the ones that we should be using. Of course, funding streams, particularly to ensure equitable access. And then the last one, which is the one that I'm going to focus on for the rest of this talk, is that clinicians need better and more education and training in food as medicine. And the data that I'm going to show, and when I'm talking about the health professional, I'm going to focus on the physician because that is my particular area of research. The data can be similarly applied to all health professional. As an integrative physician, I greatly believe in the team-based approach, and that every person in the healthcare profession who touches the patient makes a difference in their outcomes. Now, nutrition and disease can relate to everything from food scarcity, food insecurity, food choices. Are we eating too much? Are we eating too little? Is there disordered eating, like anorexia or bulimia? But what we'll focus on briefly, because the most data exists, is that of the physician's role in screening, diagnosing, and treating obesity. So let's look a little bit more at that data. And I think everybody on this call is aware that we have an obesity and diabetes epidemic in our country. And so making an impact here would make a big impact in our overall country's health. Obesity is multifactorial. On the outside of this circle, you can see macro level forces. So these are things like urbanization, economic growth, In the next circle, we see things like the food environment, the built environment, what are socioeconomic and cultural influences, and then that of genetic influences. In terms of the physician and the one-on-one patient visit or the group visit, we're really looking at the impact that can potentially happen in this inner circle, related to an individual's behaviors, particularly related to diet, physical activity. And so the question is, does counseling actually make a difference? Because some physicians will say, well, it's not worth my counseling because, patients do what they want. Or they may say, that's not my role. That's a nutritionist's role. And so they won't bring up nutrition as part of their visit. So let's look at the truth behind that. Well, it turns out that, yes, physicians can empower their patients to make health-promoting behavior changes when it comes to diet. This meta-analysis of 12 studies looked at physician weight advice and actual patient weight loss, and it found a positive association across the board. These studies were of variable sizes in different populations. Some were diabetic, some weren't. There were different ethnicities that were measured. And also what's interesting is that it seemed that regardless of whether more advanced counseling took place or even just simple recognition and discussion of the health link to overweight and obesity occurred, both of those had a positive impact on a patient's attempts to lose weight. A 2014 analysis of data from NHANES, which is the National Health and Nutritional Examination Survey, where a subset of Americans complete phone surveys that go in depth into their health and nutrition behaviors, found that patients who were overweight and obese, who reported that their physicians had spoken with them about weight, were 2 times more likely to lose over 5% of their body mass in the following year. So the answer is yes, certainly physicians can make a role, and this should be part of our care of overweight and obese patients. So how are we doing? This survey that was published in the American Journal of Preventive Medicine found that and this was back in 2018, that less than half of primary care physicians were tracking BMI or providing nutrition education for their patients. And this is despite major organizations, really across the board, recommending screening and counseling patients for overweight and obesity. So this was back in 2008, and there's been a lot of data, a lot of awareness about the changing map and the changing landscape of obesity in our country. How have we been doing since then? This survey just published earlier this year in the American Journal of Preventive Medicine showed we weren't really doing any better with overweight patients. 48% reported that a healthcare professional helped with healthy eating and physical activity. Only 35% reported they were advised to lose weight. We're doing a little bit better in the obese population. 63% had reported getting some advice about eating and physical activity, and 70% had been told they should lose weight. So why is this so low overall? Well, as an example, this was a study that asked physicians, this was done in Canada, that asked physicians why they didn't deliver dietary advice in patients with hypertension. The barriers that the physicians reported, I think, can fall into 4 categories. One was a knowledge barrier. So fewer than half felt they knew what the guidelines were, and they also reported they didn't know what foods were high or low in sodium. They weren't confident. They felt that possibly these findings were controversial about sodium and hypertension. 50% felt they couldn't keep up with the guidelines and didn't really know what to recommend. Lack of time was a big one too. Of course, we know that's an ongoing issue with the short time that particularly in primary care, that physicians have to talk to patients. And then there was also a lack of trust. So they thought that their patients wouldn't be truthful about their diet or follow their advice. When these physicians were then asked what they could do to help overcome this barrier, they listed 3 things. The first was having tools in the electronic medical records. The second was access to dietitians. And then finally, and again, the one I'm going to shift to now, is having more nutrition education and medical training. So let's look at the current state. And this is, an example of what a typical nutrition lecture might look like in medical school. Again, looking at a PowerPoint lecture, although this would be done virtually nowadays. So I would say that the data on nutrition education currently in the US medical schools is not very appetizing. The most recent survey found that only 29% of schools were offering the recommended 25 hours of education. The average hours was about 20 over 4 years of medical school. And a lot of those hours are actually inpatient or not particularly relevant to the outpatient clinician. And then a test for 4th-year MD-DO graduates that were just entering a pediatric residency. So they just completed medical school, they're new doctors. They had a very basic nutrition test, and the average score was 52%. So I would say this was a grade F. This wasn't limited to pediatrics. When a cross-sectional survey of interns in internal medicine, surgery, and OB-GYN were asked about how confident they felt to counsel patients, 71% felt when they were given a really brief, specific patient case that they could not address the nutritional needs. And sadly, they weren't wrong. When they were given some knowledge questions specific to this case, they did not score well. This isn't unique to the United States. This red flag about the lack of nutrition, we're seeing concerns in Canada, in the UK, across Europe, in Japan, in the United Arab Emirates. Our Australian, New Zealand colleagues are concerned about students being able to provide nutrition care and practice. This was from Portugal. And here we see it in Africa as well. And so across the globe, this is a summary that was in Lancet in 2019. They looked at 24 studies that have been conducted really across the globe and concluded that nutrition is insufficiently incorporated into medical education, regardless of country, setting, or year of education. Can we make up for this? So what's happening in continuing medical education for physicians who are already in practice, completed their residencies or fellowships, and are now clinicians seeing patients? Well, this review of cardiovascular continuing medical education conferences concluded that despite, and I think I would say heart disease and cardiovascular disease is a field that is one of the biggest proponents of the link of nutrition to disease, they really didn't have any increase in nutrition-related programming. This is an example from a conference last year. You can see that nutrition and diet out of a 3-day conference were given 15 minutes, and not enough for clinicians to really gain confidence or expertise in helping patients. And you can also see at the bottom what a typical conference meal might look like. So there are a lot of opportunities to add nutrition content into medical education, but there's also a lot of things that we really don't know yet. So context. Should these be electives? And if they're just these specific modules, should it be student selected versus mandatory or compulsory? Should they be across modules? So for example, nutrition in cardiovascular disease unit, nutrition in endocrinology. And if so, how is that going to happen? That's a much more complex need versus just creating an elective. And then how are we going to teach? Are we going to give lectures? Is it at the bedside? Is it just an online course? You know, should the students or learners be the subjects themselves? Community service, teaching kitchens and culinary medicine are focused for today. And then a question about what's the optimal timing? Should this be, you know, is there too much in undergraduate medical education and graduate medical education where they're trying to master all of the medical knowledge and skills, and should this happen afterwards? Or is it better for it to happen early on and then continue, which personally is my preference, because I think the earlier we can emphasize the need for nutrition as part of care, the greater the opportunity to impact patients. We are seeing more continuing medical education specific to culinary medicine. Of course, the Healthy Kitchen, Healthy Lives from Harvard and the Culinary Institute of America was one of the earliest and remains one of the greatest options. So for attendees who are listening today, I encourage you to explore that. Great to go to Napa. The other nice thing about all of these conferences is that they have the best food you can imagine at a conference. Sadly, not something we get to experience virtually. This is another example of a continuing medical education one I think we'd all like to do. In this one, participants took a 16-week online course, and then the physicians went and other health professionals went to Tuscany for 2 weeks, where in Italy, where they had culinary lessons, they went on organic farm tours, they got to taste different Mediterranean foods. And after that, they had significantly improved knowledge and self-efficacy. Unfortunately, I think this is pretty limited in terms of its scalability. I do want to mention and do a brief call out for the Teaching Kitchen Research Conference coming up soon in November, because this is now going to be virtual. It is going to be free. And so I encourage anybody who's interested in what's happening in teaching kitchen research to explore and register for this upcoming conference. Okay, so shifting from continuing to graduate medical education, these are residents and fellows, very busy. Schedules are difficult to coordinate because they're in different rotations. Preventive medicine is a little calmer in that area. This pilot took 15 residents. They did 3 training workshops with an MD chef, and then the preventive medicine residents had to teach some skills to community members. And in this, they reported significant increase in self-reported cooking competency pre to post, and some trends toward increase in their own home cooking and belief that lifestyle medicine impacts patient behavior. So I don't consider this a particularly robust study in any way. It did have some trends. I think 3 training workshops is doable in most residencies or fellowships, but for the investment of time and resources that it takes to put those on, I think we want to see more data to show that it actually works. There's been a lot more data in undergraduate medical education, and particularly through the Gold Ring Center for Culinary Medicine, which was the first, which at Tulane University, this was the first full-fledged teaching kitchen in an academic institution. And under the founding director, Timothy Harlan, they've created this multifaceted curriculum that's been adopted either in full or in part by many different health schools. There are studies called CHOP, it's the Cooking for Health Optimization with Patients medical student study, and it's really the largest multi-site cohort study to date. This data used over looked at over 3,000 trainees from 20 medical schools. They were taught by an interdisciplinary team that included chefs, dietitians, and physicians. That does vary school to school. And then the data that they looked at compared a cohort that did this hands-on cooking and nutrition education compared to traditional medical school curriculum. And they showed that there were significantly improved student competencies in counseling patients on nutrition and in their own adherence to a Mediterranean diet, which is a big focus of the Tulane curriculum. And that Gold Ring program inspired our team at Northwestern. And we considered using their curriculum, but decided that we wanted to create our own. And there were a few reasons behind that. One is that we are an integrative medicine program, and we wanted to have a more integrative, holistic approach to the nutrition curriculum, including concepts like the gut microbiome and the role of nutrition, inflammation, the anti-inflammatory diet concepts, and really move beyond the Mediterranean diet. We also wanted to focus in the culinary portion specifically on plant-based nutrition. So we think that is, as the data shows, and that I discussed earlier, what we should all be eating more plant-forward diets. And so all of the food that we cook is plant-based. And the other thing is that we wanted students to practice motivational interviewing skills related to nutrition, and then have an immediate impact on our community by doing service learning. To accomplish this, we partnered with Common Threads, which is a not-for-profit. And you can see highlighted in the colors that our mission statements have common themes. We're about community, education, and prevention. And so we've been great partners since this started back in 2016, because there's really this synergy in our missions. Together, we envisioned a culinary medicine curriculum for medical students and other health professional students who would apply then their knowledge at public schools in Chicago in at-risk community. And the goal was to impact those children and their nutrition, but then also even the medical students and their own self-care. We were fortunate to receive several seed grants for academic community research partnership, and that had helped us in our early years to make this happen. What we created then was a series of 6 classes. So these are 6 classes where the students learn nutrition concepts and then come into a kitchen together. In this case, we're using, we don't have a teaching kitchen at Northwestern. We begged and borrowed and are using the hospital kitchen in the basement of the hospital. And we go there in the evenings and cook and prepare food together. And then interspersed are 4 community sessions where the medical students go into a Chicago public school and teach grade school children about nutrition. In each of the 6 lessons, you can see here there is a range. In each one we focus on different categories. We do include public health sorts of things like food access, the environmental impact of dietary choices. We have a curriculum that runs through that is on coaching and cultural competency, and then of course culinary skills. We also aligned these with medical school core competencies like communication, system awareness, and personal awareness. It's important for this to happen and to have alignment with the ACGME competencies. What evolved after our first iteration of the course, we've now had 7 cohorts go through our elective, is that we decided to progressively make this almost all active learning, which is really a movement in education overall. And so this, of course, hands-on cooking and going into the schools and teaching. This experiential learning is a complex type of active learning. But even before that, you know, we got rid of us standing in front of the class and giving a PowerPoint and watching them glaze over. We tried to make the whole thing active learning. So instead, what happens is for each of the 6 classes, we created a set of small videos. They total about 45 to 60 minutes per session, looking at different things, everything from mindful eating to goal setting and food RX for gastrointestinal states. So the students watch this before they come together for class. In class, then, of course, we go into the kitchen and cook together. And then also you can see here what happens after they cook together is they eat a shared meal, and then our review. Each week the students are assigned an article to read that relates to some public health and nutrition subject, and the students lead and have very rich discussions. This has become one of their favorite parts of the class. They also practice coaching together, coaching each other, and then they apply that when they go into the Chicago Public Schools. We use an adapted curriculum from Common Threads called Small Bites. And again, I think the medical students really enjoy this interaction with the students. And I think that the grade school students also really enjoy getting this curriculum from medical students. My favorite story is we have the students right at the beginning of class stand up, and we let the students ask questions. The grade school students ask questions, and at one of them raised their hand and asked the medical students if they were, she said, are you guys kids or are you adults? And all the medical students looked at each other and they were like, we're not quite sure. So I think that these grade school students see the medical students as closer to their age. They're not as intimidating as when they go to the doctor, but they also carry a different weight when they talk about nutrition versus them getting it from their regular teacher. So we do a whole series of pre and post assessments that include 3 categories: dietary intake, their nutrition confidence, attitudes and behaviors, and then their confidence in nutrition counseling. So just to give you a little bit of the data, you know, we've shown significant increase in confidence after the course in basic nutrition counseling, as well as in obesity counseling. They have increased confidence in their own cooking, as well as preparation type things like how to plan their own meals, do food prep. And then we've had other outcomes too. We received and implemented an award for community engaged research, honoring the work that we had done between our community and academic organizations. We have a publication that shares all of the data from our initial cohorts and have done a lot of presentations. We've also hosted 2 Train the Trainers. We didn't make it this year yet because of COVID, but we've trained 25 attendees from 14 institutions across the country in order for them to implement Cooking Up Health. Once they get once they complete the one-day training, we give them all of our videos, all of our access that they can use however they want. And then the last transition that I want to talk about, and what I would call a success, is that like many things, we had to go virtual. We were in the middle of a cohort in spring when COVID hit. And at this point, we had done 3 in-person sessions, and the thing was, should we just stop or should we go virtual? And we decided to go virtual. This was actually really successful, and the medical school asked us if we would be willing to create a 2-week virtual elective because they needed more options for medical students. And so we ended up creating a 2-week concentrated elective. And in this, we had to add new modules. So we have 10 modules. So we built in a new one that was culinary medicine for the underserved, a day specifically on micronutrients, one on culinary and medicinal herbs, and then a 4th one, which I'm blanking on right now. And that was on popular diets and fad diets. And so in that class, you know, we would have the students do their pre-work, read articles, watch videos, and then come together in person for things like student-led debates, as well as 4 sessions when I set up 2 cameras to show what I was doing, and I prepared meals. We had sent them recipes and grocery lists, as well as a gift card to get some groceries ahead of time. And then 4 times over the 2 weeks, we all cooked dinner together. And then briefly, this is all preliminary. We're actually reviewing the data later today. We found that in this virtual format, that consistent with our previous data, students in the virtual class showed increased confidence in nutrition care and obesity counseling. They had increased confidence in their own cooking and food prep skills. They were able to stay engaged in the course, and they enjoyed cooking along and also found value, even if they weren't able to cook, which is what happened with our very first cohort, where we had to divide it up and make a rapid shift, and they just watched cooking demos. They also found that valuable. So we think that this has a lot of promise, because there are schools who don't feel like they have faculty able to bring this on. They don't have teaching kitchens. If we can do virtual culinary medicine classes, we can really scale this up. So I think this is very exciting. And now the last thing I'm going to do, because I always think seeing something in action is better than me talking about it, is I'd like to share a brief 3-minute video before we hit questions that shows what happens. This was made by the Take Care campaign. The longer video you can see on the takecare.org website, but I'll just show you a brief excerpt.
Mel, do you have the sound playing on your side? We're not hearing the sound.
Oh, the sound's not working. Okay, I guess the sound's not working. Okay, I'm just going to tell you that you can go to the takecare.org website, because apparently the sound's not working. Okay, so it'll give us more time for Q&A anyway. So I'm going to just conclude with this statement from that Nutrition and Medical Education Systematic Review. Despite the centrality of nutrition to healthy lifestyle, medical students are not supported to provide high quality, effective nutrition care. Medical education can be enhanced by institutional commitment to make nutrition education compulsory in medical training. Establishment of nutrition competencies to provide a benchmark for nutrition knowledge and skills to be included in curricula, and supported by funding for innovative curriculum initiatives. These initiatives will improve nutrition and community training to support future doctors for the 21st century. And so with that, I'll conclude, and I'm happy to take questions and hopefully provide answers.
Great. Can everyone hear me? Thank you so much, Mel. That was terrific. Before we start, can I just ask you to say again, how can the attendees see the video that you were going to show?
Yeah, if you go to takecare.org, which I highly recommend because they have great videos, but also the 8-minute version is even better than the 3-minute version. So takecare.org, and the documentary, the mini documentary, is called Cooking for Life. And it follows the story of Kamya, one of our medical students, along with one of the community students. And I see an email. Can you share my email? It was up on the last slide, but I closed it quickly. So Melinda, well, the rapid one is mring@nm.org, and you're welcome to reach out to me.
Okay, terrific. So we have a ton of questions, actually. We'll see how many we can get through here. So the first one I wanted to bring forward was this question regarding like fat phobia and fat shaming. So one of the attendees asked, so I'd love to hear some thoughts about how to approach the conversation with patients about losing weight when the number on the scale and the BMI may be an imperfect reflection of a more complicated process. And when eating disorders are extremely high, and we want to partner with patients rather than reinforcing fat shaming. What are your thoughts about that?
Yeah, that's interesting because I have definitely had my own patients come to me. I had one patient come to me and she said her gynecologist had grabbed her belly and said, "You've gained weight." Okay, not a good approach in terms of counseling a patient on losing weight, although it did make an impact. I think this is where motivational interviewing comes into play, and learning those skills can be helpful, because motivational interviewing really gets at what the patient's goals are at. And so it is not so much the physician telling the patient to lose weight as eliciting from the patient what their goals are, and then helping them understand why their weight may be a barrier to them achieving their goals. So I think shifting to that approach and getting training in that approach is what I would recommend.
Great. So another question, a few questions actually that were centered around sort of education around other barriers to healthy eating, such in the environment or sort of socioeconomic barriers, and then as well as sort of cultural meal preferences. How is that all incorporated into this education?
Yeah, so that's actually a very big part of what we do. I think right now in this moment in time, that idea of cultural sensitivity, about diversity, about understanding somebody's barriers is so important. It is why we try to go beyond this concept of the Mediterranean diet, why a different cuisine is focused each time, why each time we focus on, for example, in the articles, we'll talk about when review data on food access, food equity. Now with the new Culinary Medicine for the Underserved, we have a full day that brings in curriculum talking about those barriers and helping the students and the learners understand, first of all, why you shouldn't just tell somebody what to do, why understanding what they have access to is so important. But also even, getting beyond this idea of the Mediterranean diet and thinking of variants that are more relevant to somebody's own culture. Oldways.org is a great example of that. If you go to oldways.org, they have their example of the Mediterranean diet pyramid, but they also have versions that are for Latin America, for Asian populations. And so when you hand somebody a pyramid that's like that, then it's going to resonate more, because they'll be like, oh, this is what I eat. You're not telling me just to make a puttanesca. You're saying, oh, I can still keep eating the vegetables and the proteins I'm used to. So I think that idea of cultural relevance and personalization is a core part of what we try to share with people.
Yeah, so important, so important. So there were some questions regarding the role of other healthcare providers. Some of the data that you showed, a lot of the data that you showed was that physicians' advice make a difference, and the medical education is not up to snuff. But what about sort of other healthcare providers? And I think some of the questions were regarding how are the dietitians incorporated, but also more about other maybe integrative providers, allied health professionals. Like, how does that all fit into this mix?
Yeah, so right. So the data I showed was on physicians, and regardless of my personal belief of how it should be, the reality is that in our society, the physician is oftentimes the team leader. And also, most of the data has been on the weight of the physician's opinion when they talk to a patient about behavior. I would say, I think that integrative professionals are, for example, the traditional Chinese medicine practitioner, Ayurvedic, I think nutrition is inherently more important in their practice and becomes part of their practice. I think there can be some conflict when a patient is receiving diet advice according to, for example, a TCM principle, and they're getting different advice from a physician and they don't know how to fit those together. So this is where I think the integration is important. I do think that, what we talk to the students about is that they're not becoming dietitians, registered dietitians or nutritionists after this, that they need to have a certain level of knowledge, but then we still need to access health coaches and nutritionists and refer to group programs. So, I think that idea of system-based care and team-based care is also a part of what we try to tell people. I also think that the same curriculum we have here could be used by any school. It can be used by a nursing school, it could be used by a TCM school, a chiropractic school. The content is really for all learners.
Great. So I think one more question I'm going to try to get in before the end of the hour, and that's regarding, how has sort of, for physicians that are trying to or faculty, at medical schools that want to try to start implementing this type of a curriculum in their own institutions, have the faculty been supported and to do this type of work, and is that sustainable?
Yeah, so I'll say I think the virtual format is going to make this super sustainable because it's super low cost and it really just takes a faculty time. We have, as part of our Train the Trainer, we've created really a checklist kind of thing of what needs to happen, who you need to get buy-in from, the process of getting curriculum approval. I think there are barriers. I would say the biggest barrier that we've seen in participants who have done the training is funding, because there is at least a startup cost when you're trying to get all the equipment and the food, and if you're hiring a chef to come in and do the training. The other barrier has been access to a teaching kitchen. That's where I think we can get creative. Certainly this virtual model works and overcomes that barrier altogether. But then also, these pop-up kitchens are also a great option for those schools. I think the other barrier, which is that of having a faculty person at a school that feels confident enough in their own nutrition knowledge or culinary skills to be able to teach this, we've really tried to take that out of the mix, because all of the content is there, the videos are provided. You don't have to be a specialist in nutrition to help facilitate, because that's really what the faculty is here. They're a facilitator of learning, and they can learn themselves.
Great, thank you so much. Yeah, so sorry for those folks. I know there were other questions that we didn't quite get to, but hopefully Melinda was very, very gracious to share her email. So perhaps you'll get some feedback from this. So thank you again.
Yeah, my pleasure.
In the virtual format, you don't get to see everybody clapping, but I'm sure we had a very rich presentation and rich discussion. So thank you so much. A few announcements at the very end. So next month, we have on October 6th, our clinical grand rounds, which will be training medical students in health coaching. And this will dovetail very nicely, I think, with Melinda Ring's talk regarding, some of this curriculum. The presenter is Ruth Wolliver, who is from the Osher Center at Vanderbilt University. And then in November, we do not have our usual grand rounds on the first Tuesday morning, but instead, we will encourage everyone to register for our virtual Integrative Medicine Network Forum, which will be on November 6th, 2020. I believe that's on a Friday. And you can register on our website. And the forum will be focused on resiliency, education, and diversity within integrative medicine. And I also want to just call out that we will be, there's a call for abstracts, and that is actually, that deadline is actually coming up in 10 days on September 18th, sorry. And we're looking for abstracts in 3 categories: 1, basic and translational research; 2, clinical research; and 3, educational research and educational initiatives. So something like what Dr. Ring has just described would be perfect for this. So thank you again, everybody, and we'll see you next time.